Hi guys, I'm Sarah. I'm one of the first years, and today I'm going to talk to you guys about blast injuries. So what I'm going to talk about today can be broken into three main parts. First, I'm going to go over different types of explosives and scenarios in which an explosion might happen, because there's a clinical significance to that. That's important for us to know. Then I'm going to go over the different types of blast injuries and the four main categories of them. And then I'm going to discuss the approach to initial management of these injuries and specifically focus on injury patterns in primary blast injuries. Okay. So explosive devices can be broken down into two major categories. You have high order explosives and low order explosives. And as I just mentioned, it's important to know which is used in a blast injury because they cause different types of patterns of injury that we need to be aware of. So high order explosives create a supersonic overpressurized shock wave, which is known as a blast wave. And this blast wave causes specific injury when it hits an individual. Examples of high order explosives are TNT, nitroglycerin, and ANFO, and these are typically used in the mining industry. Low order explosives might be more common. They're typically used in terrorist attacks. Low order explosives don't have this blast wave. They tend to cause damage due to fragmentation, and these include pipe bombs, gunpowder, and Molotov cocktails. Both high order explosives and low order explosives create something called a blast wind, which is a superheated wave of airflow, which can propel someone away from the site of the blast and cause injury. And then other things to consider. So if you get a call from EMS and they tell you that there is some type of explosion, something to ask was if it happened in the open air versus was it in an enclosed space, like in a bus or a train? Because, for example, with those high order explosives and that blast wave, if that blast wave happened in an open air explosion, you can assume that that blast wave is going through an individual once. Versus if it's in a closed scenario, like a bus or train, that blast wave can hit someone multiple times, and they're most likely to have more serious internal injuries. So here I'm just going to briefly go over the four main categories before I delve into them in more detail. So the way you can think about it is think about what hits you first. So primary blast wave, blast injury, is due to the blast wave. That's the first thing that's going to hit you. Next are fragments from the bomb. That causes secondary blast injuries. Third is an individual being thrown from that blast wind. So that's going to be tertiary blast injuries. And then quaternary blast injuries is everything else. It says burns there. It's not just burns, but burns are very common. Okay. So primary blast injuries are due to the blast wave, so that makes them unique to high order explosives. That initial high pressurized wave is then followed by an underpressurized vacuum. And these pressure differences cause damage to tissues with an air fluid interface. So the ones most susceptible are the lungs, GI tract, and tympanic membranes. And I'm going to go into more detail of those injuries now. So starting with blast lung, this is also known as pulmonary barotrauma. This is the most common fatal primary blast injury. Signs of this are usually on initial presentation, but it can be delayed up to 48 hours in a patient. Clinical signs include a classic triad of apnea, bradycardia, and hypotension. And you should suspect this in people that have dyspnea, cough, hemoptysis, or chest pain. When you get imaging on these patients, as you see on the chest x-ray there's this classic bat wing or butterfly pattern, and that's caused by interstitial and alveolar filling defects. You can also see what it looks like on CT here. So the pressure differentials that I just mentioned across the alveolar capillary interface can cause hemorrhage, pulmonary contusion, pneumothorax, hemothorax, and pneumomediastinum. So something else that happens when this interface is disrupted is you can get an arterial gas embolism. And this is actually a major cause of cardiac dysfunction and death immediately after an explosion. So sometimes these patients don't even make it to you in the hospital. So the risk of this is greatest 24 hours after the explosion, and the risk of it is increased with the use of positive pressure ventilation in a patient. So this can present in many ways and affect many organ systems. So you can have coronary, intestinal, or cerebral ischemia, hypotension, mental status change, and immediate death. And I'm not really going to be focusing on CNS injuries in this talk, but it is something I just think we should be aware of. If you have a patient coming in after a blast and they're showing signs of a CNS injury, you should differentiate if it's due to an air embolism or if it's from direct CNS trauma. Okay, next I'm going to talk about the most common organ that's injured in a primary blast injury, and that's tympanic membrane. So the tympanic membrane is very sensitive to changes in pressure and always needs to be assessed in any type of explosion. Injury usually depends on orientation of the ear to the blast. You should suspect this in a patient that has deafness, tinnitus, and vertigo. The ossicles can also be dislocated if the pressure is high enough, and disruption of the oval or round window may also cause permanent hearing loss. So it is something to think about if you see a ruptured tympanic membrane in your patient. And the last primary injury I'm going to focus on is issues with the GI tract. So rupture of the colon is the most common immediate injury that happens, sometimes small intestine, but usually not as much, and this can happen immediately. It can also be delayed, and that can be in the setting of mesenteric ischemia or infarct that was secondary to an arterial gas embolism. Rupture and hemorrhage of solid organs like liver and spleen can also happen, especially if an individual was very close to the center of the blast. And of note, anatomy of children puts them at higher risk for this type of primary injury. And if it happens underwater, underwater blasts tend to have a higher presentation of GI issues. You should suspect this in patients that have abdominal pain, nausea, vomiting, hematemesis, rectal testicular pain, or any unexplained hypovolemia. Moving on, I'm going to talk about secondary injuries now, and this is the most common injury in blast victims and the leading cause of death, except in issues of major building collapse. This is caused by flying debris and bomb fragments, and these images here are actually from the Boston Marathon bombing back in 2013. So you can have damage from primary fragments, which come from the bomb itself, or secondary fragments, which come from the explosion. So for example, glass from a broken window. Many homemade explosives and in terrorist attacks involve weapons that have nails and screws added to the bomb in order to increase the amount of injury. And you should look for internal injuries, even if there's only a small puncture wound on the patient. For instance, if they got hit with a nail, it might not be that significant on your initial exam of them, but then when you get these x-rays, you see that they have some type of retained injury. Okay, next, tertiary injuries, and this is from individuals being displaced by that blast wound I mentioned, which is in both high and low order explosives. It can present similarly to injuries in the secondary injury pattern, but you're gonna see more blunt trauma, fractures, and traumatic amputations in tertiary injury. Okay, next is coronary injuries, and this is basically everything else under the sun that didn't fit under those first three categories. So this includes burns, chemical exposure, toxic inhalations, crush injuries, dust inhalation, and also exacerbations of any pre-existing conditions such as asthma or COPD. Example of this would be all the respiratory illnesses that happened after 9/11 can fall under coronary injury. Also, any complications in patients that are on anticoagulation or complications in pregnancy. Now, I know I said I was going to mostly focus on primary blast injuries, but I do just want to mention crush injuries and burns because I think it's something that we definitely need to keep in mind. This falls under coronary injury. And in the case of structural collapse, there's a very high mortality rate due to crush injuries and entrapment. So crush injuries can lead to metabolic derangements that result from damage to muscle tissues, causing release of myoglobin, urates, potassium, and phosphates. Also, along with burns, can result in rhabdo and renal failure. And both of these injuries can lead to compartment syndrome. So when you're examining a patient, it's just something to keep in mind. First things first is we need to anticipate what's coming in. So that's why it's important to talk to EMS when you get a call about something. So find out if it was an enclosed bombing such as bus or train, because they're more likely to have primary blast injuries. Of note, less injured patients usually present first because these are the patients that are going to bypass initial EMS triage and go to the hospital. And general approach to these patients are just like that of any other trauma patient. Always assess airway, breathing, circulation, and follow ATLS guidelines. All wounds should be considered dirty. Don't do primary closure. Give tetanus shots if it's indicated, and give prophylactic antibiotics. But you do need to keep in mind specific injury patterns in blasts and how this can change management. So initially, this was an algorithm that was followed, and you can loosely use it to guide your management. So like I mentioned before, tympanic membranes are the most sensitive to that initial blast. So if a patient already has injuries present, treat them for those injuries and then look in their ears. If they have ruptured tympanic membranes, you should have a very, very high suspicion that they're going to have a barotrauma, either pulmonary or visceral, and you should be observing them and getting imaging. Now, it was previously thought that if a patient didn't have obvious injuries present, you looked in their ears and their tympanic membranes were intact, that you can discharge them and don't have to worry about any type of pulmonary or visceral barotrauma, but that is actually not true. So a study that looked at the train bombings back in Madrid in 2005 showed that out of all of the patients that had pulmonary barotrauma, there was a good number of them that had completely intact tympanic membranes. And if you discharged them home, you would have missed those injuries, and which would have led to high numbers of morbidity and mortality. So, all right, you look in their ears and you see that they have ruptured tympanic membranes. These patients should absolutely be observed for 6 to 8 hours, look for signs of any delayed pulmonary symptoms, and have a very low threshold to get imaging on these patients. Even if a patient does have intact tympanic membranes, you should still consider observing them for at least 4 to 6 hours to make sure that they don't develop any pulmonary symptoms. You don't need to necessarily rush to get imaging on them right away, but it is something that you should, again, have a low threshold for because you don't want to miss any type of blast lung injury. Okay, so some specific primary injury management. So let's say you observe your patient and you're very confident that they only have isolated tympanic membrane rupture. So these patients, when you discharge them, they're going to need an ENT follow-up to make sure that they don't have any dislocation of the ossicles or any damage to the round or oval windows. Also discharge them with ofloxacin odic drops. But then you have a patient that does have signs of blast lung. The way you manage these patients is you're going to manage them as ARDS. You want to be very cautious with high positive pressures because that's going to increase the risk of pneumothorax and arterial gas embolisms. And you also want to be very mindful of fluids. So if you have a patient, let's say, that has rhabdo, crush injuries, burns, and they need to be fluid resuscitated, but they also have pulmonary barotrauma, the way that you would resuscitate them with fluids is you titrate the fluids to adequate urine output. Because if you give them too much fluids, like say if you follow the Parkland formula, you can end up pushing them into pulmonary edema. Okay. If a patient has an arterial gas embolism, you want to use FiO2 of 100%, place them in the left lateral decubitus position, reverse Trendelenburg. And once the patients are stable enough, they can go to a hyperbaric chamber. And in a patient that has a GI injury, obviously if they have a ruptured colon, they're going to go to surgery. But if you don't find anything initially, but you have a high suspicion for it, just do serial exams and imaging because GI barotrauma can actually have an even more delayed presentation than that of pulmonary barotrauma. I read that it could be days to weeks, especially if it has to do with mesenteric ischemia. So it's just something that if you have a high enough suspicion for it, you should be doing serial exams. Okay. So in summary, just to quickly go over it, primary injuries, the things that hit you first is that blast wave, and that's going to cause barotrauma. Secondary injuries are things that are thrown at the victim. So those are projectiles and typically cause penetrating and blunt injuries. Tertiary is the victim being thrown by that blast wind, and that's going to cause a lot of fractures and traumatic amputations. And quaternary is everything else, including exacerbation of already existing medical conditions. Remember that intact tympanic membranes do not rule out other injuries, and most patients are going to warrant a period of observation. And that blast lung is the most fatal barotrauma injury. So manage it as ARDS, use minimal positive pressure, and be very cautious with fluids, titrate it to adequate urine output. Thanks. Any questions, comments, concerns? No? Okay.